This is a keyword review on cardiovascular termed keywords that were frequently missed on the June 2025 ABA Basic Exam. My name is Laura Pinault. I'm an anesthesiologist and program director at the University of Kentucky. These are the keywords that we will review in this slideshow. The first is cardiac anatomy and a review of the coronary circulation. The second is cardiac output and the determinants of. The third are adrenergic drugs and their receptors. And the fourth is Dabigatran and its laboratory evaluation. The coronary perfusion originates from the ascending aorta in the aortic sinuses, near the aortic valve root. There are two ostia that give off a left main and a right main coronary artery, which is shown in the image on the right. From there, branches occur to perfuse the myocardium. The left main branches to the left anterior descending and the left circumflex arteries, which supplies most of the left ventricle. The right coronary artery travels further and primarily perfuses the right ventricle. It has a right marginal branch and the posterior heart. The posterior circulation of the heart mainly comes through branches of the posterior interventricular artery. In roughly 80% of individuals, this supply is via the right coronary artery, so that's important to know for your tests. The venous circulation of the heart, by contrast, is not talked about as much. It happens largely via the coronary sinus. The cardiac veins drain into the coronary sinus, which in turn empties into the right atrium. There are also smaller cardiac veins which pass directly into the right atrium. The major tributaries include the great cardiac vein, labeled GCV, which becomes a coronary sinus posteriorly, the small cardiac vein, labeled SCV, and the middle cardiac vein, labeled MCV, and also the left posterior ventricular vein, or LVPV. The RCA most commonly supplies the SA and AV nodes. This is important because inferior wall MIs are more commonly associated with bradycardia and heart block. A common application of this knowledge for your test will be to produce ischemia in an EKG lead and ask what regional wall motion abnormality or symptom might the patient have. You can map these to these different territories, and the schematic below is showing you that. It's just one way of looking at the difference between the left and the right coronary circulations. Again, of note, the right coronary primarily perfuses the right posterior and inferior heart, as well as the AV and SA nodes in the vast majority of patients. So remember that inferior wall MIs can be associated with bradycardia and heart block symptoms. This table just provides another way of looking at this same information. Leads V1 to V4 map to the anteroseptal LV and would be tributaries of the left anterior descending artery. Leads V5 to V6 and 1/AVL map to the lateral walls and are tributaries of the left circumflex artery. Leads 2, 3, and AVF look at the bottom or inferior portion of the heart and are tributaries of the posterior descending artery, which is mostly comes off the right coronary artery. Leads V7 to V9 are labeled here. They're unusual leads, but they are posterior leads, and they can augment looking at the posterior heart if you're noticing reciprocal changes in other leads. The R designation leads are right leads that are specially placed when you want to look at RV function and are another modification of the EKG. They are mapped below in this table. Another application of this is to describe the regional wall motion abnormalities and ask which coronary territory is most likely affected based on findings on echocardiography. Presented below are common echocardiographic views for evaluating regional wall motion abnormalities. On the left are the focused TTE views with labeled walls. Remember that inferior walls are typically supplied by the RCA, lateral walls by the left circumflex artery, anterior walls by the left anterior descending artery, and the infundibulum, where the right ventricle funnels to meet the pulmonary artery, is typically supplied by the RCA. I recommend viewing these slides or similar slides often prior to your test, because there's a strong memorization component to these patterns. Moving on now to keyword number 2, which is the determinants of cardiac output. The formula for cardiac output that we all know and love is stroke volume times heart rate. Hemodynamics can be described in multiple standardized terms, however, and many different variables, in fact, impact the cardiac output and the hemodynamics. The standardized terms are known as the tropies of the heart, and I define them for you here. They include inotropy, which describes the contractility of the heart, chronotropy, which describes the rate of conduction through the SA node, dromotropy, which describes the rate of conduction through the AV node, bathmotropy, which is the one you're least likely to have heard about, describing the excitability of the heart tissue, and lusitropy, which describes the relaxation of the heart. Chronotropic medications affect sympathetic versus parasympathetic tone. Dromotropic antiarrhythmics are often used for the treatment of atrial fibrillation or other dysrhythmias, and they can include amiodarone, beta blockers, calcium channel blockers, and digoxin. Adenosine will stop conduction through the AV node with a very short half-life, but it is a negative dromotrope. A positive dromotrope could include isoproterenol. A note on bathmotropy. An easy way to think about it is the irritability of the heart. Positive bathmotropes will increase ectopy and dysrhythmias by making it easier for the action potentials to fire. Positive bathmotropic medications could include norepinephrine, epinephrine, digoxin, dopamine, and dobutamine, while negative bathmotropic medications include beta blockers and amiodarone. Positive lusitropic medications that increase relaxation of the heart include milrinone, dobutamine, nitroglycerin, and nitroprusside, while negative lusitropic medications include beta blockers. To be accurately interpreted, cardiac output must be evaluated in the context of all of these variables. Most often, we do not directly measure cardiac output, but rather use mean arterial pressure as a surrogate for organ perfusion. Mean arterial pressure is calculated by the cardiac output times the systemic vascular resistance. And remember that the most important mechanism for changing systemic vascular resistance involves changes in vessel lumen diameter, or changes in vascular tone. The Poiseuille relationship shows that resistance is inversely related to the fourth power of the vessel radius. In chronic hypertension, the vessel radius is often reduced because of a thickening of the vessel wall. This leads to reduction in lumen size. I'm going to talk a little bit about inotropy and the relationships, compliance relationships of the heart. Normally, compliance curves are plotted as a change in volume over the change in pressure. For the ventricle, however, it is common to see it plotted as a change in pressure versus the change in volume. See the figures below. Therefore, the slope of the relationship is the reciprocal of the compliance, which is sometimes referred to as ventricular stiffness. As the ventricle fills with blood and its volume increases, the pressure within the ventricular chamber passively increases. See the normal filling curve in the figure. The relationship is not linear, however, particularly at higher volumes, because the compliance of the ventricular wall decreases, or the stiffness increases, the more the ventricular wall is stretched. This occurs in most biological tissues. The compliance of the ventricle is determined by the structural properties of the cardiac muscle. For example, the muscle fibers and their orientation and the connective tissue, as well as by the state of the ventricular contraction and relaxation. For example, in ventricular hypertrophy, the ventricular compliance is decreased. The ventricle is stiffer because the thickness of the ventricular wall increases. Therefore, ventricular end diastolic pressure is higher at any specific end diastolic volume. See the figure below. Alternatively, at a given end diastolic pressure, a less compliant ventricle would have a smaller end diastolic volume. Filling will be impaired. Other cardiac disease states, such as restrictive cardiomyopathy, can also decrease ventricular compliance. If ventricular relaxation is impaired, as it occurs in some forms of diastolic heart failure, the functional ventricular compliance is reduced, which will impair ventricular filling. In a disease state such as dilated cardiomyopathy, the ventricle remodels and becomes very dilated without appreciable thickening of the wall. Remember this, the positive inotropes generally move to a more favorable position on the Frank-Starling curve as diagrammed on the slide. The third frequently missed keyword involved adrenergic drugs and their receptors. Adrenal receptors are distributed throughout the body in the central nervous system, such as the alpha-2, and the smooth muscle of the blood vessels, myocardium, and bronchioles. Three groups are described, alpha-1, alpha-2, and beta, with various subtypes listed in the table on the left. They are G-protein coupled receptors that are activated by the binding of neurotransmitters from the autonomic nervous system. Alpha-1 works by breaking down phospholipase C and increasing intracellular calcium. Alpha-2 and beta receptors work through a G-protein activation of adenyl cyclase, which breaks down ATP to cyclic AMP. They respond in opposing directions to sympathetic and parasympathetic tone. Note that alpha-2 adrenoreceptors are also agonized by sympathetic neurotransmitters such as norepinephrine, epinephrine, and dopamine, but the agonism of these receptors results in a negative feedback loop that is sympatholytic in nature, meaning it decreases further norepinephrine release. Neurotransmitters that potently agonize adrenoreceptors are synthesized endogenously via the adrenal gland. They include epinephrine and norepinephrine. The effects are summarized in two different types of images. You can see on this branch diagram on the left, as well as the diagram on the right, which are giving you a lot of the same information, just presented in different font. Note that the sensitivities of the adrenoreceptors to norepinephrine and epinephrine vary among the subtypes, and this is listed on the right-hand side, part B of that diagram, where they describe the sensitivity of the alpha and beta receptors to epinephrine and norepinephrine being equal, greater than, or less than. There are various mnemonics to remember sympathetic tone and what happens, such as fight or flight response, and what happens to various blood vessels and organ systems in terms of secretory responses, etc. So I would recommend reviewing that information in the table below. This slide is just to remind you that alpha-2 receptors are a little bit different and a little special among the adrenergic class. They are agonized by sympathetic neurotransmitters, but they act as a negative feedback of the sympathetic nerve stimulation. They also work centrally in both adrenergic and non-adrenergic neurons for many desirable anesthetic synergistic effects, for which we commonly select the use of dexmedetomidine, for example. These can include effects like hypnosis, sedation, anesthetic sparing, and analgesia effects. The fourth and final keyword that was highly missed related to Dabigatran, or brand name Pradaxa, and the pharmacological evaluation of its function via the lab. Dabigatran reversibly binds to the active site on the thrombin molecule, preventing thrombin-mediated activation of coagulation factors. It is a direct thrombin inhibitor. It may have less of an antagonistic effect on thrombin-mediated platelet aggregation. Furthermore, dabigatran can inactivate thrombin even when thrombin is fibrin-bound. It reduces thrombin-mediated inhibition of fibrinolysis and therefore may even enhance fibrinolysis. It does not have any indication in dual antiplatelet therapy for the prevention of atherothrombosis after MI or coronary intervention. Dabigatran exilitate is the bioavailable oral formulation, and it is converted by liver hydrolysis to the active form. It is not highly protein-bound in plasma. It is not dependent on CYP-P450 metabolism, and it is formulated with tartaric acid to ensure reliable intestinal absorption independent of the gastric pH. It therefore has generally predictable pharmacokinetics and dosing, in contrast to warfarin. The time to maximal plasma concentration and maximal clinical effect is about 2 hours or less. The plasma half-life is approximately 12 hours, and dosing is therefore twice daily. Clearance is predominantly renal, and the drug will accumulate in renal failure. Dosing modifications are fairly straightforward given the linear metabolism. Because of its predictable pharmacokinetics, Dabigatran does not require routine close monitoring of clotting function, as warfarin does. If monitoring is required, a prothrombin time, or INR, which is a measure of the extrinsic coagulation cascade, or an APTT, a measure of the intrinsic coagulation cascade, are not quantitatively accurate for the effect of Dabigatran on the clotting function. These tests are instead replaced by the thrombin time or the eccrine clotting time. The thrombin time is easy to understand as simply a measure of the time to clot formation in the presence of thrombin. Because Dabigatran is a direct thrombin inhibitor, it will prolong this time. The eccrine clotting time is a specific assay that uses the snake venom eccrine to activate prothrombin, making it a more targeted method for monitoring direct thrombin inhibitors like Dabigatran and Dabigatran. Eccrine clotting time provides a more linear response and accuracy for these specific drugs compared to the standard clotting tests, which can be affected by factors like prothrombin and fibrinogen levels. In patients with normal renal function, Dabigatran levels will fall to 25% of steady state concentration after 24 hours and about 6.25% after 48 hours. Therefore, it may be reasonable to cease Dabigatran 1 day before an elective procedure without a high bleeding risk, but earlier in higher risk procedures like spinal procedures, cardiac procedures, etc. The length of time the drug needs to be ceased obviously needs to be increased in patients with renal impairment, and an APTT, thrombin time, or eccrine clotting time can be measured to ensure they are within the normal range, but the APTT alone is not as diagnostic. I want to just briefly review the DOACs, or the direct oral anticoagulants like Xarelto. You'll see on this table as well, they talk about the different clotting tests that you can use. The effect of DOACs on the screening coagulation assays such as prothrombin time, APTT, and thrombin time is directly linked to the reagent composition, and the clotting time can be different from reagent to reagent depending on the DOAC's reagent sensitivity. Liquid chromatography, or mass spectrometry, is considered the gold standard method for DOAC measurement, but it's time consuming and it requires expensive equipment, so clinically it's not relevant. The general consensus for the assessment of a DOAC is clotting or chromogenic assays using specific standard calibrators and controls. So this concludes the slideshow of these 4 cardiovascular frequently missed keywords on the basic exam. I want to thank you for listening, and I hope you enjoy all these recorded presentations that we will continue to provide.